Hello, it's Dr. Jay Shore, Director of Telemedicine Programming for the Department of Psychiatry. This is the clinical considerations tutorial for the COVID situation. If you have been going through these videos in order, you may be getting a little tired of me introducing myself, but at least you won't forget me, hopefully. Let's get into some highlights of clinical considerations of video conferencing with patients. I think the first concept we really need to address is this idea of virtual space. And this concept, whether we're communicating with a patient over video, telephone, or email, talks about that space which we inhabit, the communication, which is different than being in person with them. I like to think about it as having strengths and weaknesses. Virtual space can have some advantages over in person. For some examples, as you can see on the slide, right? It's convenient, it can be more immediate. We can observe their home environment and get more information about the patient in the environment where they actually live versus our clinic environment. It can help, and there's some data in the literature, patients who are more anxious, avoidant, have a harder time getting out. In person, there is, more of an immediacy to in-person interaction. Physical boundaries can set this therapeutic frame. We certainly have ample research and guidelines for in-person care, although we now have it for video care, and it's certainly considered the gold standard. There is sort of this dynamic, particularly between video conferencing. I think you do lose a little immediacy over video conferencing with a patient, but you gain a little bit more objectivity and observing ego in a session because you are step back a little bit. Certainly, you don't have the full picture of the room. You only have what's on the video, and you don't have smells, which can add an important component. For example, a patient who's mildly intoxicated, and so you do lose that. But also, for better or worse, in the virtual space, there is some of the advantages of what we call virtual disinhibition. And like with everything, advantages and disadvantages. So virtual disinhibition is this concept that over technology that all of us, and particularly patients in the clinical setting, may be a little more disinhibited. A great example of this, I'm sure you can all think about, some work emails where people probably convey too much information or share things that they probably really shouldn't in a work setting, and in a way that they would never share in person, but they felt comfortable doing it over email. I think the same may be true in video conferencing. It's a little bit subtler, but particularly when you're seeing patients in their home, their guard is a little bit down, and you're getting sort of maybe a less sort of staged or guarded version of their behaviors in themselves. There's also, in some ways, just a feeling of a little bit more confidentiality, often over video conferencing, and also with particular populations, there's a physical safety issue for the provider, right? And working in certain institutions with violent offenders, it's safer to do over video conferencing. But same that goes for patients, right? Patients with trauma and PTSD often will say that they feel more comfortable and have a more sense of a control of the session over video, and a stronger sense of safety, which again may enable the work. So being attentive to the virtual space and what's going on both with you and the patient is really critical. I'm going to just move myself over. Let's talk a little bit about sort of presentation and managing that space. So first of all, when you're doing video conferencing, you really want to come across a little bit more on the screen. And that means if you're 100% in person, you go 105, 110%. You don't want to be over the top and yelling and gesticulating and just in someone's face. On the other hand, you want to work to come across and project yourself in this space. And so one of the things, so some of the things to consider first is how you're appearing to the patient. So one is the light, do you have a stable video connection? Can you see and hear each other clearly? So that's important. Once you've established as a stable video connection, making sure, particularly what the lighting is in your room. Sometimes backlighting's a little better. The lighting you see on me right now isn't optimal. I can't control the lighting right now in this room, but I probably have it a little dimmer. I can tell that I'm getting a little shine off the top of my head. Could say a guiding light, but maybe if I had indirect lighting, there'd be a little shine. Being aware of your background. My background here is fairly neutral. It's also fairly unexciting. You can create a nicer background with a bookshelf or, the same background that you might have at an office desk. So being aware what the patient's seeing. If you're working with a particular population, when I do my clinics to the Northern Plains native communities, I often will have a star quilt in the background, which is something that's very familiar up there to those patients. Also, with high definition video conferencing, you don't have to worry as much about what you're wearing, although in the early days of video conferencing, striped shirts could blur and be distracting the vision. So having solid colors can be helpful. It's not critical. Paying attention to eye gaze. Now with the video conferencing into our phones and into our computers, often eye gaze isn't such an issue. As you can see, I'm coming to you from an old video conferencing unit where you had the camera up on top. And so where you were looking and then where the patients were seeing could often be off. And so what we know is that less than a 7% difference in the angle of our eyes making contact with our eye gaze is optimal. Again, it's not, with these newer video conferencing system, it's not so much of a factor. It is really important to have your picture-in-picture on so you can see what the patient is seeing. For some providers, it makes them a little self-conscious. For some providers, they enjoy watching themselves and seeing themselves talk. And so people have sort of different feels for that. But if you don't have that on, what can happen is you can end up here and you're talking and the patient, and you don't really realize how you're visually coming across and thinking you're having a great session when you're off camera. You can also use the distance, even if you don't have a camera that can zoom in and zoom out, you can subtly use distance, your distance from the camera to communicate sort of different states. So if I'm back here, it may create a little bit more sense of distance, maybe a little bit more of an initial approach, and create some boundaries. If I'm emphasizing a point, if I were confronting a behavior specifically, I may come a little closer to the camera. Or if we were talking about something that was more difficult and to create a sense of empathy. The other thing, again, that sort of 105% is just trying to speak clearly and articulately, being animated with the patient, and engaging probably in a little bit more small talk than you would if the patient were in the room with you. So for example, often when I'm video conferencing with patients, I'm doing that at a distance, and so our weather is different. The weather's always an easy introductory sort of comment to make and ask them what the weather is or what the situation is, where they are. One, to show your interest, but also to get more information. When you're doing direct in to home as appropriate, when you see the patient's background, you may see pictures, you may see objects, and asking them about that. If there's pets present, asking about the pets. I think one of the keys to virtual space management is that in person, there is often more of a feeling of control over the clinical interaction. And when you do video conferencing, your patients at a distance, providers may feel that they're giving up some of the control over the clinical setting. I really like to say is you're really giving up the illusion of control, because we don't have a lot of control in our offices over a patient's behavior, and we're not going to assert physical control, and that's the same over video. And so when you're working with a patient, you are still responsible for that clinical environment and setting, and so it's important that that you don't see control over the session. Meaning, if you see behaviors that the patient's engaging in that you would confront in person, that you need to go ahead and confront them. You need to be assertive in controlling the environment. So when you're meeting with the patient, you can ask them to adjust the camera and change the angle that you're seeing them at, so you can get a fuller picture of their face, for example. Change the lighting. Remind them it needs to be a private, secure environment. If there's a pet in the room and you feel like the pet's distracting, then you need to ask them to remove the pet from the room. If you make the judgment that it's therapeutic or helpful for the session, and by all means keep it in there. If there are people unexpected coming in and out of the room, then you should set limits on that. If there's too many distractions, ask the patient to create a private space for you. So really making sure you don't see control just because you're virtual, like any session. As the provider, you're responsible for the session, the environment, and what's happening. Here's a few additional sort of don'ts and tips as we look around. If you see, again, you want to create a private, secure space, both in your setting and the patient's. Always introduce others in the room. Sometimes patients are off camera. And particularly in the patient's room, as you get going and start a session, particularly at an intake or with a new patient, do the video conferencing, you're ready to say, hey, I'm assuming there's no one else in the room. If there is, please introduce me. And if at future sessions there's anyone in the room off camera, I would like to be introduced. You can see, as we've talked about backgrounds and some of the don'ts, I would not place things in the background that you wouldn't have in your normal office. You can see that this particular slide says no sports items. I'm not sure that that's too controversial to have a few sports items in your background, but certainly in this era, sort of political banners, religious symbols, and the type of things you would probably not disclose in your in-person office. It's good to be mindful of. We've already talked about the lighting, placement of the placement of the webcam, and also I think I have decent placement in this shot of the video. I'm maybe a little closer, a little farther. Again, if you're going to wear stripes or patterns, give a test run to make sure that isn't sort of too distracting in the video. I am not one to give good fashion advice, and I'm not one who people seek out in that area. So I would say that probably everyone watching this would have better judgment about best outfit selection. We've talked already a little bit about that. Small talk, active listening, which we should all be good at, hopefully at behavioral providers. A little bit more checking in too. I think it's okay. Sometimes it can be a little harder to read emotions. So saying, I can't help but notice you looked upset. Can you tell me, is that right? Can you tell me what you're feeling right now? So a few more queries can be helpful in managing video conferencing. So a couple, two final things. One, the space-time continuum paradox of video conferencing. When we see patients in clinic, we are sharing their environment, and we're aware of that. When you're seeing patients back-to-back over video conferencing in multiple clinics, sometimes the settings, in their homes, they look a little bit different, and it reminds you that their environment is different. When you're seeing patients over video conferencing in clinics, you may forget that. And particularly if you're really going across distances, very quickly you can find yourself in a completely different environment for the clinical care of the session that has a different set of resources, including emergency backup, benefit types of resources, healthcare resources, and then obviously doing work. All of our work is cross-cultural every day, but you certainly can really transmute very quickly national boundaries and culture. Most of us won't be doing this in response to the COVID. We're going to be seeing patients that we're already seeing in the Denver area, but just a reminder that developing an awareness of those issues and the environmental context, working with rural patients, for example, and understanding in rural communities different values and how you discuss firearms, how you may have to manage boundaries of rural environments between staff you're working with and patients you see, the impact of community events and timings. And again, that's true with urban populations, and understanding that with the COVID, right, that there may be different accesses as we go into quarantines and stuff to resources, and certainly not making assumptions about our patients and how their environments are interacting and impacting their mental health. But of course, that's just good clinical practice, whether we're over video or in person. So finally, this is my contact information, and I'm available. I would also conclude, as I keep this up, with just briefly some tips for having a new patient over video conferencing. So when I have a patient who's never video conferenced before, I'll first turn on the session. I'll say hello, introduce myself, and I'll ask them if they can see and hear me clearly. After I address any audio or video issues, I introduce myself if I haven't met the patient, talk about my credentials and the organization I'm working for. I will then ask them, have they ever used video conferencing to see a healthcare provider? If the answer is yes, I'll say, oh, good, you're used to this, although I'll continue to go through my spiel. If they say no, I'll ask them if they've used other video conferencing with friends and family to assess their level of comfort. I'll then let them know that if they're new to video conferencing, this may be a little different at first, but what I'll tell a patient is that most patients get used to this fairly quickly and find that this is a very convenient way to act. So I'm sort of trying to bias them in favor of video conferencing with statements like that. I'll then review sort of a consent process, here's the risk benefits of video conferencing. If you really did not want to be seen, we could try and see you in person. Now, obviously during the COVID situation, if you have an appointment, they're probably opting to be seen over video conferencing. I will then briefly talk about any workflow procedures, about scheduling follow-up, and any emergency protocol associated with the clinic. This is how to contact me after hours. I will, during this time, ask their location, and I'll say I need that in the unlikely event I would need to get some additional in-person help for you. I will also explain during the consent process that video conferencing is much like being seen in person, and the same rules of doctor-patient confidentiality apply. What we do here, I document in your medical record, which is confidential within the system of care you're being seen, but other providers and people that you've given permission to can have access to that medical record. And I also will let them know, like I would in person, in the event of an emergency where I thought there was a danger to self or others, I may need to break confidentiality and talk to whoever I need to talk to keep people safe. So after I go through, and I went very quickly, I go slower when I'm talking with the patient. After I go through that spiel, I ask them if they have any questions or concerns before we get started with the intake part of the examination. When I'm finished, I'll check in with them again and sort of review next steps and workflow and contact. And then I'll ask them if they told me they were new to video conferencing. Well, how did you feel about that? What's this like for you? And for those patients that are new to it, when I see them the next time, I'll also check in again. I usually do that 2 to 3 times until they're not having questions, or they're telling me, hey, they're liking it, it's going well, and there's no concerns to address. So that concludes the clinical discussion of the tutorials. We hope that these have been helpful, along with the other information that's been provided. In addition to myself, the department has a great administrative team. We are all here to support and help you during this time. So please reach out with questions or issues that are arising around using video conferencing. And so this concludes this tutorial.